Okay, then I'll be quiet.
Good timing. So we are going to go over the skin today, and then in lab we are going to go over the skull and kind of go over all those parts. So that's kind of on tap. Um, Hopefully people have started studying for the test coming up on Thursday. With that, we're going to go ahead and have you guys enter the Zoom meeting and take the test while you're on Zoom. That's just kind of the way that we've been doing proctoring for the exams, is by having you guys be visible while you're taking the test. So everybody needs to be ready to have their webcam on for when we take the test. Got a couple people that just entered. We got that clicked over. So after you take the test, depending on how long it takes people, we may cover a little bit of lecture for the bones. That's our next chapter that we'll be moving into. We've kind of already covered a fair amount of it in lab, but we'll kind of touch on some of the general, hopefully we'll have time to kind of finish up just talking about some of the general components of bone and reviewing how bone is organized, and then move into kind of the more specific parts of the appendicular skeleton in lab moving ahead next week. So that's kind of the game
When you
plan.
said test, are you talking about this morning's quiz?
So we have the quiz this morning, but then we have our first actual written exam is Thursday, covering the first 5 chapters.
Right. Okay.
That we've gone over.
That sounds like fun.
During the quiz too, I really want you to stay on Zoom and take the quiz while you're visible with that until we get back on site. That's just kind of how we're doing it. For some reason, Olivia is having a hard time getting in the room. I keep clicking admit, but it still says joining for her. All right, so let's talk about the skin. I'm gonna share my screen here. All right. So the skin, also known as the integumentary system, one of our 11 body systems that we've got. Let me get everything else visible that I'm going to need visible. I'm not seeing my chat. I'm trying to make my chat visible, but it's hiding on me somewhere. There's my chat. All right, now I think I got my act together, more or less. So the field of physical therapy, actually, one of the first big body systems that we really dealt with back when we had veterans coming back from World War I that were injured was the skin. You had a lot of battlefield injuries that involved soft tissue, but clearly you had entry and exit wounds from the bullets and shells going off and things like that. But we also had a lot of chemical burns. And so we have a long history of being involved in wound care and taking care of people's skin. And it's an area of practice that is less and less emphasized as we've kind of shifted to having so much of the field based in an outpatient setting. And so a lot of those wound care skills have kind of fallen by the wayside, but that's actually, I did a fair amount of wound care my first years out in practice. And so we definitely need to understand the skin. Even if you're just working in an outpatient orthopedic clinic, you're going to have people that had ACL surgeries, rotator cuff surgeries, and their incision sites can create excessive scar tissue that might limit how well the joint functions. You can also kind of get binding of different layers of tissues as they cut through the skin, the connective tissues into the joint capsule. A lot of times those different tissue layers can kind of seal together onto each other rather than being separate layers that can kind of shift. They'll kind of all get stuck together. So we need to have a good appreciation of how the skin heals, how we prevent injury, and then in later classes you'll get into more of the wound care part about specific choices of dressing types and bandages and things that you want to use depending on the characteristics of that person's wound.
I have a question.
Uh-huh.
So the things you're talking about, is it because like the skin is like, say the fabric's too close and if it gets sewed together too tight, it restricts movement?
Yep, absolutely. Lots of
Okay.
anything that's got any kind of significant scarring, um, you'll notice that that skin doesn't move as well. You know, when we'll look at how we kind of heal, just basics at the very end of today's lecture. Um, but we don't really replace skin with the exact replica of how it was. We fill it in largely with collagen. And so it doesn't have the same mixture of elasticity that it used to. It tends to be a lot more just rigid, tough, um, tough tissue as opposed to more pliant, stretchable type of tissue that used to be there in that area of the skin. Um, so so yeah, it definitely can create a lot of restrictions when we get too much scar tissue forming and we let it proliferate and we don't work to make it as flexible and movable as we can. And so you'll learn about different ways, kind of massage techniques to kind of keep that skin more supple, more pliable, and more stretchy so that the joint itself has full range of motion.
So it's like sewing on a piece of burlap or something stronger, but it's not as stretchable and it's just patching up over the room. Like it doesn't make the same fabric as before, it's just patching it up.
Yeah, I mean, if you imagine like your skin being more like lycra, where it's going to give and stretch kind of in all directions, if instead of having replacing that a tear in lycra with lycra or with lycra thread, we're essentially going to tie it down with thread that doesn't stretch. And so then that area is not going to move as well. And if that part of the skin that has a lot of scar tissue doesn't move as well, in order for us to get good motion, the tissue surrounding that scar has to give that much more. And then that makes it kind of susceptible to injury too. So it kind of creates a domino effect. So I'm seeing a lot of comments. People are having issues with Zoom today. I'm kind of not being smooth. It's probably because it's Tuesday. Hopefully it'll straighten out. I don't know if there's anything I can do to switch it. All right, so we're going to talk about epidermis and the dermis. We've talked about the epidermis when we looked at a lot of the tissue slides, and I talked about the squamous cells that we have, how we have so many different layers. But we'll kind of look at all the different layers that we have in the epidermis. We'll kind of look at how the dermis is put together, and then the tissue that's beneath the dermis, kind of our body fat layer, the subcutaneous layer. So that's kind of the main stuff that we'll be looking at today. So you'll see this slide a lot, or some version of this slide, and this is kind of trying to give you the big picture. Have a little model that kind of looks the same right there. And I'll probably pull that out a little bit too and amplify the image so you can kind of see. So when we look at the very top of this, you can see the hair coming out of it. We've got this kind of pinkish layer, and this is the roughly 20 to 30 cell thick layer of squamous cells that are the ones that we're going to shed really easily off the top. So these are the ones that we all have tons of them in our bedding right now, unless you got this morning and washed your sheets. You're going to have a ton of these little top layer of cells, and these are dead. They're filled with the keratin, which is that waxy kind of waterproofing substance. As we start moving down through the layers of the dermis, you start getting into this kind of more visible purple line. And then we have a whole nother set of kind of purple cells in the midsection. And then we have this one kind of wavy purple line that's traveling across the slide horizontally. And so all those layers, that kind of pinkish layer through these different shades of purple, that's all the epidermis. Beneath that, we have the dermis, and the dermis layer on this slide essentially goes down until you see these kind of horizontally oriented blood vessels that are running across. So the dermis is kind of this pinkish layer. We've got a bunch of blood vessels going up into that area. We've got sweat glands, we've got the hair follicle, oil glands, some different things that allow us to pick up sensory information. And so we'll kind of talk about all those different things. But again, this one down at the bottom that has these kind of yellowish ovals, those are meant to represent fat cells. So this is kind of our subcutaneous body fat layer down below. So we've got subcutaneous, we've got our primary blood vessels, and then we move into the dermis, and then up into the epidermis. So that's kind of the general kind of big picture, and we're going to kind of dive into each one of those sections and look at how they're made up and what they kind of do for us. So on the whole, we've got a lot of different things that the skin is going to do for us. Protection is a big one. This is our outer covering against the outside world. Now we have openings that are naturally occurring, our mouth, our nasal passageways, our ears, things like that, that have mucous membranes, and we have our own way to kind of protect the body against invading organisms that come into those open spaces that are supposed to be there. But the skin really is designed to give us kind of that protective covering to keep germs, bacteria, viruses, things like that from getting inside of our body. But obviously we get injured, we get cuts, we get lacerations, we get abrasions, and that does open that up so that things can get in. And that's why it's important to, take care of any wounds and limit how much opportunity there is for bacteria to get into the body. Our skin's going to give us protection from the sun. If we did not have that skin covering, even if you are really fair and you burn really easily in the sun, if you didn't have that protection, then you're talking about your body's tissues getting sizzled. So muscles and fascia and things like that would be getting damaged from the sun. We do absorb some things through the skin. It's not totally impervious. If we think about like putting on a sunscreen, you're going to absorb that sunscreen into the skin to a degree, and that provides some layer of protection for us. So it can be a good thing, but it can also be a bad thing if we're exposed to harmful chemicals and we start absorbing those through the skin. When I first got married, my wife and I bought this dining room table at a garage sale, and it was a nice older piece of furniture, and we decided to refinish it. And so I had on just like Rubbermaid gloves or something like that, and I was using a varnish stripper, like a turpentine type solution, and that stuff got absorbed into my nail beds, and my nail beds looked very wavy, kind of like where this papillary layer is, where these little waves are. That's kind of how my fingernails were. Instead of having a nice kind of flat surface, it was literally like this going across my nails, and it took months for that to grow out. So the gloves that I had worn and using that harsh chemical were not protective enough. My fingernails absorbed that chemical, and it definitely wreaked havoc on them. So I learned my lesson. Get better gloves the next time. I ended up giving up on the project and outsourcing it to let a professional handle it after that. Mostly because I got to the chairs, and the chairs had so much detail. I was like, oh, this is way too hard to do. So a flat tabletop is one thing to refinish. When you're looking at stripping chairs with lots of contour, that's a different deal. So that's my advice.
Kids, don't try this at home.
Pretty much. You might think you're a DIYer, but you have to know your limits. Go with your strengths if you want it to look good long term. So our skin's gonna, in addition to protection, it's gonna kind of help us hold on to some water so that we don't dehydrate really quickly. We don't turn into a raisin every time we go out in the sun because we're just shriveling up. So it's not perfect. We definitely lose some moisture vapor through the skin. And if we're in a body of water for long enough, our skin is going to absorb some fluid too. So it's kind of considered more water resistant than waterproof. It can keep the water out within limits, but if we soak in it for a long time, then we are going to soak up some of that water. Thermoregulation is a huge role of the skin, and it does it in combination with the circulatory system. Really, our body is gonna, if we're overheated, we're gonna cause vasodilation in the skin so that more blood can get to the skin, so that we can let that hot blood have a better chance to dissipate some of its heat. If we're very cold, we're gonna have a lot of vasoconstriction, so we're not gonna let the blood go to the skin because we want to hold on to that heat. We want to preserve that heat. And the more surface area that we have where we have a lot of blood flowing through it, the easier it is for us to lose heat through the skin. So it does a pretty good job of that, but it definitely has its limits. You know, it's not like a big down puppy or anything like that in the winter. All right, some other roles of the skin that you may not have considered. It does play a critical role in helping generate vitamin D. So we can take in vitamin D in the foods and things that we eat and drink, but our body has its own ability to make vitamin D also, but we do need to get out in the sun for it to occur. And so there's this kind of balance between, well, we don't want to prematurely age our skin, put ourselves at risk of skin cancers by just going out in the sun all day long, but we do need a little bit of daylight exposure to generate some vitamin D, and we see problems with more problems with vitamin D deficiency in the winter when the days are shorter, people are inside more, people are wearing more clothing and don't have as much skin exposed to the sun. But it's not that much to generate the vitamin D that our body needs. I think I've read that we only really need like 15 minutes or so of exposure. And again, it's going to depend on how much of your skin is exposed within that 15 minutes. What we do.
Comment?
What's that? Yeah.
My sister and mom had thyroid problems, and actually going in the sun actually helps with their depression.
Mm-hmm.
So if any of you have been sad or something, but you don't know why, maybe just try taking a walk in the sunlight, and it might actually help a lot.
Yeah, for sure. Sunlight. I mean, we have seasonal affective disorder, which is kind of an interesting acronym because it's SAD. Is kind of that condition linked to depression in the winter being much more common when people aren't able to get out as much and enjoy some fresh air and daylight and that kind of stuff. So it is a real thing, and for sure it can affect mood. And that's not listed on here directly. I guess it's not necessarily the skin per se helping with that, but just the environment more so. So we do have defense cells that are embedded in our skin so that even if our skin is intact, we still sometimes can get some organisms that can penetrate through. And certainly if we have an open wound, then it makes it much easier for an invading organism of bacteria, virus to get into the body. And so we do have some cells that are embedded in the skin to kind of serve as kind of those frontline soldiers against invading organisms and try and kind of help deal with them. And if it's not too bad of an infectious process, then that sometimes is adequate. A lot of times they might need to mount a more systemic response to deal with that organism too. So sensation is a huge role for the skin, and we'll talk about that a little bit. And then secretion. So we're going to make sweat to cool us off, and then we also make oils. How many people have had a zip before? Maybe one or two of you. Okay. So those oils are basically sebum. And when you get that kind of more whitish appearance, that's really just kind of pus, white blood cells that have been dealing with some sort of infection, small infection at the level of the skin that causes that kind of whitehead that you're going to pop and everything. But our hair follicles are basically where the oil producing glands are kind of tied into. So those oils basically kind of wick their way up the shaft of the hair to get to the surface of the skin, where it can then kind of spread out and kind of help serve as lubrication, make that outer layer of the skin a little bit more pliable, but also help with kind of the waterproofing part too. So I'm going to play a little video here, and hopefully it doesn't freeze up on you guys too much as you're watching. This is about 8 or 10 minutes long. It's from a website called Crash Course that does a great job with both anatomy and physiology videos. Pretty entertaining guy, and his content is really good. He's a professor at University of Montana. And so I'll use these periodically over the next couple semesters when we're going through a lot of concepts, just to try to make it kind of give you a big picture, and then we'll kind of dive into some of the stuff that he discusses in there. So hopefully it'll play for me and play for you guys. We might have an ad first. It's been known to happen.
When you hear about your organs, you probably think of your heart or your liver or your lungs. Maybe you picture Captain Nemo playing the organ aboard the Nautilus. Why do they have an organ on a submarine? That doesn't really make any sense. But your first associations with that term probably overlook your biggest organ. I'm talking about your skin, the glorious fleshy shroud that keeps the world out and you in. Your skin protects your body against infection and extreme temperatures, maintains your balance of fluids, and even synthesizes vitamin D for your own personal use. Its many nerve endings allow you to sense the outside world, and its sweat glands and blood vessels help you maintain a proper temperature and communicate a whole range of stuff from your health to your emotions through things like blushing and flushing and sweating. It also accounts for about 3 to 5 kilograms of your body weight, and if you could spread it out, it would measure up to 2 square meters, enough to cover your bed. The most disgusting, paper towel thin, waterproof, insulating, stretchy, self-repairing, lifetime-lasting quilt on the planet. It comes in lots of different colors. You can cover it up or show it off or tattoo the periodic table on it if you want. And of course, without it, you would basically shrivel up and die in no time. Together with your hair, nails, and sweat and oil glands, your skin forms your integumentary system. And if you've ever been burned or had surgery or stepped on a nail, you know how fast complications arise when it gets damaged. But it also heals up quite quickly.
You guys hear it okay?
Layers. Like an everlasting gobstopper, the key to your integumentary system is layers. And although you can't tell by looking at it, your skin actually has 3 of them, each with particular types of cells that have their own skin jobs. To borrow a phrase from Blade Runner or BSG, whichever you like, the epidermis is the only layer you can actually see, assuming that your skin is intact, which is why it's what you think of when you think of skin. It's made of stratified squamous epithelial tissue. But the dermis just below it is where most of the work that skin does gets done, like sweating and circulating blood and feeling everything everywhere all the time. And at the bottom, there's the subcutis, or hypodermis, composed mostly of adipose or fatty tissue. Each of these layers owes its properties and its ability to do its skin job to its unique combination of cells. The bulk of your epidermis, for example, is made up of cells called keratinocytes, which are the building blocks of that tough fibrous protein keratin that gives structure, durability, and waterproofing to your hair, nails, and outer skin. These cells are constantly dying and being replaced. You lose millions of them every day, enough to completely replace your epidermis every 4 to 6 weeks. That's why if you want to tell the world you love your mom or commemorate your favorite famous physiologist with a tattoo, you got to make sure the ink gets below the epidermis. If there's a cell in the human body that's been responsible for causing the most pride and the most prejudice in human history, it's another epidermal cell, the melanocyte, the spider-shaped cell that synthesizes melanin, the pigment that gives skin its color. I'll spend more time talking later about why skin color differs around the world, but one thing to keep in mind is that both the very palest and the very darkest human skins on the planet have about the same number of melanocytes. Your particular color isn't about the number of these cells that you have, but instead about the breadth of their spidery cellular extensions, which in turn affect the amount of melanin that they contain. But on a cellular level, we're all the same. Now, your skin, obviously, is also your first line of defense when it comes to protecting you from the outside world, so it may not come as a surprise that you have lots of immune system cells in your epidermis as well. These are your dendritic or Langerhans cells, which are kind of star-shaped, and like white blood cells and platelets, they actually originate in your bone marrow. Once they migrate to the epidermis, their long, skinny tendrils run around the keratinocytes and spend much of their time ingesting the unwanted invaders that are trying to sneak around your skin. Finally, rounding out the quartet of epidermal cells, your tactile or Merkel cells occur deep down at the boundary between the epidermis and the dermis, where they combine with nerve endings to create a sensory receptor for touch. What's a little weird, though, is that all of these cells are organized differently in the skin that covers your body. In fact, in some places, you have more layers of epidermis than others. Your thick skin, and yes, that's what it's really called, is the tougher stuff on the palms of your hands and the soles of your feet, and it consists of 5 epidermal layers. Your thin skin covers everything else with just 4. To get to know what's going on with your thick skin, let's just imagine you're walking around barefoot in the yard and suddenly you feel a shooting pain. You've just stepped on a big old nail, and it's penetrated all of the layers of your epidermis. First, it pierced your stratum corneum, which means, pardon my Latin, horny layer. This is the outermost layer and also the roughest, made up of about 20 or 30 sheets of dead keratinocyte cells. This is the layer that you're always sloughing off and feeding to dust mites, but while it's in place, it offers basic protection from environmental threats. From there, the nail drives through your stratum lucidum, or clear layer. This holds 2 or 3 rows of clear, flat, dead keratinocytes that are only found in the thick skin of your palms and foot soles. So in places where you only have thin skin, this layer is what's missing. Things start to get more serious in the granular layer, or stratum granulosum, because this contains living keratinocytes that are forming keratin like crazy. This layer looks kind of grainy because those cells are getting compressed and flattened as they move up through the epidermal layers, maturing as they go. The deeper you go through the layers of the epidermis, the younger the cells get. Regeneration happens in the lower layers, and new cells move up toward the surface, maturing along the way, where they eventually die and slough off from the surface of your skin. This whole process is due in part to the fact that the epidermis is epithelial, so it's avascular. That means that all the oxygen and nutrients that its cells need have to come from the dermis below it. So as epidermal cells mature and get bumped up by younger cells forming below them, they move further and further from the blood supply and end up essentially suffocating. When that nail cuts through the 4th layer, the stratum spinosum, or spiny layer, it's getting closer to the point where cell regeneration, or mitosis, is active. These cells look prickly when they're dehydrated from microscope slide preparation, hence the name, and that's because they contain filaments that help them hold to each other. And finally, that dang nail touches down on your deepest, thinnest epidermal level, the basal layer, or stratum basale. It's just a single layer of columnar cells, but it's like a cell factory where most of that new cell production happens. This stratum is also what connects the epidermis to the layer of skin below it, the dermis. Feeling a little overwhelmed by all the layers? Just remember, Cub, let's get sunburned. It's a mnemonic. I mean, though, who came up with that? Because if you own some skin, you know you don't want to get sunburned. The ultraviolet radiation in the sun can damage the epidermis, causing elastic fibers to clump up, leading to that telltale leather face condition. Plus, getting sunburned temporarily depresses your immune system because, remember, you have immune cells in your epidermis too. And the radiation can actually alter your skin cells' DNA, leading to skin cancer. We're going to go into your skin's love-hate relationship with sunlight more next week, but in the meantime, seriously, wear your sunscreen. Now, skin damage of any kind can get serious when it affects the dermis because it's not only got loads of those collagen and elastin fibers which help make your skin strong and elastic, it's also full of capillaries and blood vessels. And it houses the nerve fibers that register sensations like temperature, pressure, and pain, as well as parts of your hair follicles and oil and sweat glands with the ducts that lead up to the surface of the skin. The dermis is where most of the skin's work is done, and it does it in just 3 layers. The upper papillary layer is composed of a thin sheet of areolar connective tissue that's riddled with little peg-like projections called dermal papillae. These papillae are pretty neat because in the thick skin of your hands and feet, these tiny protrusions form unique friction ridges that press up through the epidermis to help our fingers and feet grip surfaces. Your fingerprints. Just below that papillary layer is the deeper, thicker reticular layer that makes up 80% of your dermis, made up of dense, irregular connective tissue. All of the dynamic parts contained within the dermis, like the nerve fibers and capillaries, are distributed between both its layers. So anytime you get cut enough to bleed or feel pain, you know that you've broken through the epidermis and lacerated the dermis, which, by the way, is the layer that tattoo needles have to reach in order to work. It's the only way to make tattoos permanent, but also it means getting tattoos hurts and bleeds. Finally, something of a footnote to your skin is its 3rd and most basal layer, the subcutis or hypodermis. It consists of mostly adipose connective tissue, basically a seam of fat, and it provides insulation, energy storage, shock absorption, and helps anchor the skin. In short, your hypodermis is where most of your body fat hangs out. But there are more skin things to discuss, so in our next lesson we will tackle big questions like, does lotion really do anything? How does deodorant work? And what will make my hair soft and shiny and irresistible? For now, though, you learned all about skin, the main organ of your integumentary system. We looked at the structure, mechanism, and...
All right. We don't need to hear his recap, I don't think. So we'll kind of touch base on all the stuff that he just talked about. The other video link that I've got on this slide, and I don't know if it's up on the version that's on Canvas, is from the Khan Academy. And so those are also really good videos if you feel like you need some supplemental review of different concepts that we cover over the next few semesters. I would definitely steer you towards Khan Academy. They're not as entertaining as the Crash Course Guide, not quite as much humor involved, but they definitely are accurate and give you good information. So that's another good video source if you're looking for something. All right, so we talked about the epidermis. We have that's our epithelial layer. So it is avascular. There's no blood supply. So it's only those deepest layers that are really alive and are doing cellular processes. Once we get up towards, certainly the stratum corneum, those are all dead. Stratum lucidum, that's a dead layer. Stratum granulosum, they're pretty much are getting compressed and flattened and dying in that stage. So really only the spinosum layer and the basal layer, the basale layer, are the only two where the cells are actually living. Other than that, all those epidermal cells are too far from the blood supply, and so they're not really alive per se. They're still there and helping us. And that the ability to have that keratin within them is what makes them tough and strong and gives them some of that waterproofing. So that's important to acknowledge also. So these are our 5 layers. He gave you a little acronym saying to remember. I came up with my own that I kind of like better because his goes from the outside layer down, and his was "Come, let's get sunburned." I kind of like this one better because it's kind of giving you a better warning than encouraging you to get a sunburn. And so burned skin generates lots of cancer. So if you're struggling to remember which layer goes where, you could use either 2 of those little sayings, whichever one works the best for you. Just recognize that they're describing things in an opposite order. The way that he presented in that video was from the outside in. The way that I'm presenting it here is from the deepest layer to the most superficial layer. So we've got the basal layer, the spinosum layer, the granulosum, the lucidum, and then the corneum. All right, so looking at this picture, and this is kind of on the right-hand side, is just kind of a blown up of that bigger skin diagram that we kind of started with. So we've got our corneum layer at the top, this whitish layer kind of right at the bottom there, that's that stratum lucidum. And so that's usually they usually say it's 2 to 3 cell layers thick. And that's only going to be found in the soles of our feet and the palms of our hands. And so it is kind of a whitish kind of color, kind of a translucent color. And that's why even when people that have really dark skin, their palms are still going to be way lighter looking than the rest of their skin. And the soles of their feet are going to be way wider looking than the rest of their skin. And it's due to that thin layer right there. That granulosum layer are also fairly flattened. And so this is kind of where things are getting compressed enough that squashes all the organelles and they start to degrade. And this is kind of where they go to die, is that granulosum layer. This multiple layers here, and it kind of varies depending on where we are in the epidermis, is going to be that spinosum layer. And we see a few other cell types that are kind of embedded in here. This yellowish one is a dendritic cell, so that's part of our immune system response. And then this little kind of light blue one down here is meant to be a sensory receiving cell. So that when we touch something with the outside of our skin in that dead outermost layer, that force is going to be transmitted through all of these layers, and that little sensory cell is going to kind of be able to pick it up and recognize, oh, is that squashing me? Is that pulling on me? And different types of sensory cells detect different information. We have some that are going to detect like shear forces. We have others that detect deep pressure versus light pressure versus temperature. So we do have a lot of different specific types of sensory cells. The very bottom layer, the one that kind of squiggles up and down, that's our basal layer. So that's where we're going to have cell division taking place. The cells that are created in that basal layer migrate into that spinosum layer, and then as the basal layer keeps pumping out more cells through lots and lots of mitosis, it just pushes everything up towards the surface. And so as those spinosal cells get more and more compressed, then they move into that granulosum layer, And then if we have thick skin, they're going to move into that lucidum layer. If we don't have thick skin, then it goes straight from the granulosum layer up into the corneal layer, into the corneum. So those are our 5 layers. And again, the only 2 that are living are the bottom 2. Everything else is pretty much dead. You can see these little tubules kind of working their way through. And so these are going to be ducts. So these are going to be for exocrine cells that are in our epithelium. And in the case of the skin, we basically are going to have either sweat-producing exocrine glands, or we're going to have oil-producing exocrine glands. All right, so that basal layer, we've got lots and lots of keratinocytes that are being made. We do have melanocytes. He talked a little bit about that in the video. That's what's going to give our skin pigmentation, give it color. And these are going to ramp up their activity when we get exposed to sunlight, so that we can become more tan, and that darker color gives us a little bit of protection against further exposure to the sun. Now, if we get too much, then we get burned, and we have more damage. So we kind of have to take that in small doses and kind of build it up a little bit. But keep in mind, all that UV light exposure does kind of prematurely age your skin too. So there's pros and cons to that sunlight exposure. And then tactile. Tactile just means touch. So these tactile cells are what give us the ability to sense things. If it's prickly, if it's smooth, if it's, like I say, tugging on me, pushing on me, poking me, those are what are going to let us know that. All right, the spinosum layer. Again, largely keratinocytes. We do have some of those dendritic cells that kind of help us recognize when an invading organism might be trying to wreak havoc with our body. And then granulosum, essentially this is where these cells are all going to die off. They get compressed so much that they're just crushed. 3 to 5 layers of cells typically, and they are just filled with keratin in that layer. And again, as we create more cells in that basal layer, then these granulosum cells are going to get pushed up into either the lucidum layer, if we're talking about the palms or the soles of our feet, or straight up into the corneal layer. And again, 20 to 30 cells thick. We talked a little bit about calluses last time. Certainly in areas where you have a callus form, you probably have more than 30 layers. You probably have maybe 40, 50, 60 layers. I don't know. It depends on how big your callus is, how often you file it down or do whatever you do to smooth it down. And these are the ones we're constantly shedding everywhere. All right. So thick versus thin. Thick skin, about 1/2 millimeter thick. So that's not really all that thick, but compared to thin skin, which is more like about 1/10 millimeter thick, it is significantly thicker. So about 5 times thicker when we look at thick skin versus thin skin. All right. I think we looked at enough skin pictures. If we look at this one here's our stratum basale, this kind of deeper reddish purple color coming up. You can see this little pink projection going up into it. That's what's called a papillae. And then down below that, where we have this more pink, this is our dermis. And so the dermis is considered most of it mostly dense, irregular connective tissue. We do have areolar connective tissue kind of at the papillary layer, but then the deeper part, which is called the reticular layer of the dermis, is more irregular. And so that irregular connective tissue gives the skin the ability to stretch and move in lots of different directions so that we aren't restricted in certain motions. So the cells are not nearly as tightly packed as we see in the epithelium of the skin and the epidermis, a looser configuration. So we do have different things that give our skin color. Hemoglobin is is the oxygen carrying portion of the red blood cell, and so it becomes very red in color. And so when you blush, it's because your capillaries in your face have opened up a lot more, and so we're allowing more blood to flow into the facial tissues in the skin. And so that's what gives you that kind of reddish appearance. Or if you're really hot. If you've been exercising, you tend to be more flushed looking, your face is more red looking because you've got a lot of vasodilation going on to let more blood flow in there. And so it just makes that blood be more visible as it's closer to the surface of the skin. The melanin we talked about, that gives us kind of our base skin color, and it does allow us to kind of change in response to sun exposure. And then carotene is more of that yellow-orange pigment that we do get from carrots and sweet potatoes and things like that. When my son was a little guy just first starting on solid foods, we noticed that if we gave him too much of the orange colored, the heavy keratin-based baby food, he definitely started turning orange. And we were like, oh, we better give him some green beans to kind of balance that out. And it definitely made a difference. So if you have little ones and they're first starting to feed, then don't lay off too much of the orange stuff unless you want an orange child, because they definitely take on an orangish tint. All right, so there's our melanocytes kind of embedded within the other cells in those deeper layers. And they're going to kind of extend these little projections out in between the cells, kind of in the interstitial spaces, to give us a little bit more coloring, and they will become more active when we do have some sun exposure. All right, so you have some colors and blemishes in the skin that can show up. A lot of the things here are related to specific conditions that you might see somebody have. We've all heard of an albino, maybe seen people that have albinism, or animals that have it. And essentially it's just the lack of melanin in those areas. So they will be very pale in color. Their irises, instead of having, you know, blue eyes or brown eyes or any of that kind of stuff, they're going to be more pink. And essentially it's just the capillaries that you're seeing that are making them kind of pink. Bronzing, not a super common condition, but you will learn later in the program about Addison's disease, and that's one of the common diseases that can cause that bronzing color. Cyanosis is a bluish tint, most commonly seen in like mucosal membranes, the lips, oral cavity. It's basically just a lack of oxygen in the blood in that area. Definitely not a good thing to see. Sometimes you'll see it when people are really, really cold. They'll get those kind of bluish lips. And that's because your body's vasoconstricting so much to conserve heat that the face is like, yeah, that's not a big priority. Let's protect the brain and the heart and the stomach and the liver and these things that keep us alive. So we do shunt blood to the more critical organs and away from more superficial things like skin. Erythema is redness. Again, that could be after a sunburn. If you've ever had an infection, you're going to get an erythema from an increased blood flow to that area. If you've had an acute ankle sprain or something like that and you swell up a whole lot, you'll have an erythema appearance to it typically. When we have initial erythema from trauma, then it will often turn into more of a hematoma down the road, and that's just basically bruising. Another term for that is ecchymosis, but it's basically just that more bluish, purplish kind of discoloration, and that's typically just the red blood cells in that area when they start to kind of die off. And you know, we have tissue damage that lets bleeding take place underneath the skin, and then as those cells kind of degrade, they're no longer red, and they start getting those other funky colors. And bruising can be, you can see some weird colors, you know, yellows and purples and kind of greenish tint, and interesting as it fades and changes. Jaundice is more of a yellow discoloration, usually associated with liver problems. We see that a lot of times in newborns. They'll be kind of yellowish, and a lot of times if you'll get advice to put them in the sunlight for short periods of time, and the sunlight helps the body break down what's called bilirubin, which is kind of a byproduct of red blood cells that have degraded, and that's where that yellow kind of color comes from. this term pallor, that's a more of a response that we'll see. And it's a lack of blood flow. So when somebody's going to go into shock, they're going to have pallor. It's just a pale coloration. If somebody, hears really bad news, they'll get really pale. If they've been sick, nauseous, throwing up, a lot of times they'll look kind of pale. And that's what that term refers to, pallor, just kind of pale looking from a lack of blood flow. All right, and then we have kind of these glitches that you can see. Well, the last one's not a glitch. Friction ridges are normal to have. A nevus, that's a big fancy word, well, only 5 letters, but still kind of fancy compared to the 4-letter mole. So if you didn't know that, that's the technical name for a mole. It's a nevus. And then freckles are basically just smaller areas where we have a lot of melanocyte activity. A hemangioma is usually more of a deep red, almost a purplish color. If you've heard of people that have like port wine stains, the bigger kind of patchy birthmarks, those are essentially a type of hemangioma, just a big collection of capillary cells right at the surface that show up more visibly. A lot of people will have them kind of at the back of their skull. It's a common place to have a hemangioma, and other skin areas too. And then our friction ridges, he talked about in the video, that's essentially where our fingerprints are. And having that lucidum layer, I think, is enough to kind of amplify it. It's from where the papillae are, where the epidermis and the dermis meet, but we only really notice them in the fingertips, in the hands, and the feet and toes, where we have that thick layer of skin that kind of makes them a little bit more pronounced. And there's different types of friction ridges. There's no questions on the different types of friction ridges, so don't study that slide. Just a FYI slide. All right, so we're done with the epidermis. Let's talk about the dermis a little bit. We've got the papillary layer and we've got reticular layer. And this term papillae or papillary essentially just means that it has a nipple-like shape to it. So it has a little bit of a little hump to it. And we have a number of other tissues in the body that will use that term. When we talk about the heart, there's a certain part of the heart muscle that is a papillary muscle. And then the reticular layer, we talked about reticular proteins. That's just, it gives that tissue or the organ some shape to it, those reticular fibers. And so that reticular layer in the dermis is what kind of gives it shape and structure a little bit more. So in this slide, we've kind of peeled away and separated out the epidermis, which is all this stuff being lifted up, from the dermis. And so that papillary layer is essentially just all these little mounds that you see in here. It always reminds me of an egg crate mattress. If you've ever had a camping mattress, a little egg crate that has those, it kind of, if you imagine like in, a cardboard egg container, it has those little center projections to separate the individual eggs. That's kind of what it looks like in these depictions. And each of those little humps that comes up, you can see kind of in the center here, has a artery or arteriole coming up in there, a capillary bed essentially, and then a vein to kind of pull that older blood out of the area. So this is essentially having those little finger-like papillae sticking up into that epidermis allows those blood vessels to be just a little bit closer and to kind of penetrate up a little bit into that epidermal layer. Now, it doesn't go through the stratum basale, but it just moves it closer into that stratum basale. And remember, those basal cells are the ones that are constantly making new cells. So they're the part of epidermis that have the highest metabolic activity. They're going to need the most blood flow. So it's a good arrangement to have these little capillaries that are sticking up in there. You see some other little extensions coming up there that are kind of more yellow, and these would be different types of sensory nerve endings to give us information about the outside world. All of the rest of the pink if you can see on the left-hand side, that papillary layer is just that very top part. Everything else below that, until we get down to that subcutaneous or hypodermic layer, is going to be the reticular layer. And so that reticular layer is where we have the vast majority of the blood vessels, the different sensory receptors, the sweat glands, the hair follicles, all that stuff is in the dermis. So the dermis is really kind of the viable living part of our skin, and then our sub-Q layer down below. All right, so papillary layer is areolar connective tissue. So that's one of our different of the loose connective tissues. That's one of the different types. We have the adipose as well. That falls into that category. And the most important part to know, really, besides that it's the areolar connective tissue, is that that's where we're going to have those capillaries that are basically feeding the epidermis. So that's a critical part of that papillary layer. The dermis layer, or excuse me, the reticular layer is really kind of more the stretchy part of the skin that gives it that ability to kind of move as we move our arms, legs in different areas, twist, turn, bend, all those things. If we just had a more densely packed and more regular arrangement of the connective tissues, we would be more restricted in our motions. We wouldn't have the ability to move in all the different motions that we do. But it does have a lot of critical things that kind of help the skin do what it does in helping us sense the outside environment and helping us hold on to heat or dissipate heat. All that stuff is in that dermal layer. All right, now this is such a fun title: stretch marks, wrinkles, and lines of cleavage. Now, most of you are pretty young and probably don't have that many wrinkles. Some of us are a little bit older and have a few more wrinkles than others. Some of us have more stretch marks than others. And then we all have lines of cleavage. And this term cleavage doesn't necessarily refer to a low-cut blouse kind of cleavage. Cleavage just means kind of where the skin, how it kind of orients itself and how it's kind of organized so that certain parts of the body do move more freely in some motions than in other motions. And we have what are called lines of cleavage, and that's basically kind of where the majority of the collagen fibers are going to be oriented in that body area. And it helps the body be stronger in certain motions and the skin be stronger in certain directions than others. We'll look at the lines of cleavage in the next slide and kind of talk about that a little bit and how that comes into play with therapy. Anybody that's got stretch marks, essentially your skin you grew so fast that your skin stretched too quickly and it tore, and we created scar tissue in the form of collagen fibers. So now that skin that did have a high amount of elasticity to it now has less elasticity. It got bigger, and the way it got bigger was by tearing and then kind of filling in the gap with these collagen fibers. And so stretch marks are usually, compared to the surrounding skin, are usually thicker and much more white, a lot paler looking. And that whiteness is because you have a large number of collagen fibers. And those collagen fibers don't produce melanin. They don't have the same components that the rest of the skin has. So it does create kind of a different appearance, and you get those little lines. So a lot of people will get stretch marks when they go through puberty. Certainly women that are pregnant will typically get stretch marks because they've got this kid growing in them. Their breast tissue's growing a lot to prepare for lactation. And so it's pretty common for women to get a lot of stretch marks with childbirth and childbearing. But most of us have stretch marks to some degree. And then again, UV light, great for making vitamin D, but not as good for kind of helping your skin stay young looking. All right, so here's our lines of cleavage. And if we look like around the armpits, we have a very different arrangement of how the majority of the collagen is oriented compared to kind of along the rib cage. and then that changes a little bit in the lower abdomen, into the legs. And then you see these kind of sleeves around the knee that go where the fibers go more circumferentially around the knees as opposed to more kind of diagonally through the thighs. And then we have kind of vertical orientation in the calves. And so the lines of cleavage are important when people have surgery and how their scars are going to heal. If this guy, I don't know if he's supposed to have gotten stabbed or he had surgery, it was kind of more like a stab wound right there. That vertical incision is perpendicular to the lines of cleavage. And so that's going to have a hard time closing normally. You're going to probably have a lot more scar tissue to fill in this big gap compared to this incision on his calf where it is directly in line with those lines of cleavage. It's going to be easier for the body to heal that than it is to heal this. Essentially, the way that the tissue commonly gets pulled in those areas is why the collagen lines up the way that it does. It's meant to give it strength in the directions that it needs it. And one particular area that you'll see a lot of problems is that the knee, how many people have seen somebody that's had a knee replacement, what their incision looks like? So, Allie, what's it look like usually? Go ahead and unmute yourself.
It usually goes perpendicular to those lines of cleavage.
Yep. So it's usually going to be straight in the front, and it's going to be, about 4 or 5 inches long most commonly. So it's a pretty lengthy incision that's going across most of those lines of cleavage. And every time you bend your knee, essentially it wants to pull that incision apart. So we're tasked with trying to help these people get back great range of motion in their knee, but it does tug on that incision and make it more likely to kind of gap and separate a little bit. Carrie, you had a question?
I just wanted to say I actually had surgery on my knee, so I have one of those scars that goes perpendicular, and then I had incisions that did go sideways, so those ones healed better.
Yep.
But then that giant one is very visible, and you can really see it.
Yep, and you get a big chunk of scar tissue right in the middle when you have incisions that go across these lines of cleavage. If you didn't move the knee at all after surgery, then maybe the scarring is a little bit less, but your motion's going to be way, way worse. So we kind of have this balance between, trying to get the motion back, but at the same time, trying to make the scar as minimal as possible. And so we'll do a lot of, we'll talk about different scar massage techniques to try and make the collagen fibers lay down more the way they're supposed to, not lay down as much this way, and try and get them to be laying down a little bit more the way they're supposed to, kind of horizontally, to try and minimize some of that scarring and let the skin move a little bit more freely and more naturally there. So
is there like any type of a topical treatment to keep that supple and make the impact of that scarring less obvious or less detrimental?
Yeah, for sure. With you can use compression dressings can often help, because we're trying to heal, and we'll talk about that at the very end today, you're going to be making a lot of collagen, and that collagen wants to keep pushing up towards the surface of the skin. And if we put a tight dressing on the outside that kind of pushes down on it, then it kind of helps those cells recognize, oh, we got to the top. We don't need to keep making more cells. And so you can kind of minimize some excess scar formation. So especially with burn patients where they have a lot of, big sections of skin that are missing and they're filling in large areas, we'll usually have them wear compressive garments, like really tight fitting shirts and pants and sleeves and gloves and things like that, and even face masks if they have facial burns, to kind of minimize the extent of the scarring. So that's one of our better tools, is some sort of compression against that to kind of limit excess scar formation.
Hey, Craig, I have a question. So when it comes to women having to get C-sections, do they try to go along that line, or in most cases does it just go across?
The typical C-section scar is usually kind of just right above the pubic hair, so it's and it tends to be more of a horizontal incision. That's the more common type. Sometimes they'll do it vertically. That's usually more like an emergency C-section. But typically, if it's a planned C-section and they're not like in a massive rush to get the kid out, it more or less approximates what we see. I mean, those ones in the lower abdomen are coming in kind of like this, and that incision is going to be usually kind of like just a small smiley type of incision. It's not often totally horizontal. It usually is a little bit tipped up at the edges, but it could be more straight across too.
And does that affect how it, when it, I guess, heals up, do the lines eventually go back to how they're supposed to be? Or I guess,
Probably not as much. I mean, just because you're going to have, I mean, yes, they're wanting to cut the collagen normally would be kind of coming in together this way, and now we're making an incision that's more or less horizontal. So it's going to feed into that, but it's probably going to hit that border. The bigger problem is our most superficial abdominal muscles, rectus abdominis, run vertically right through there, and so they have to cut through all that tissue too. And so now you're forming scar tissue where the muscle fiber should be running this way. We're forming scar tissue kind of going horizontally across that. So it creates problems with, you know, trunk control and posture and core stability and all that kind of stuff too. So my wife had a C-section, so I'm somewhat familiar with this issue. All right. What do we have left? We got about 30 minutes. So we've got a number of different nerve fibers in the dermis. Again, epidermis, we don't really have any in there because those are just primarily kind of deadish cells. So we've talked about the different touch receptors, and we'll get into kind of the more specific ones. That's what this video link down here is for. I don't think I'm going to show it. When we get to the chapter on sensation, we'll kind of dive into all the different specific names, different types that we have for those. We do have, the nerves are going to be in charge of blood flow. So if we need to cool ourselves off, our blood vessels respond just to tighten. If we send an electrical signal that says, hey, contract, the muscles that surround that blood vessel are going to, they go circumferentially around that blood vessel. They're going to tighten up and narrow that down. So essentially, if we need to vasodilate and we're trying to cool off and send more blood to the skin, we just need to kind of turn off the excitation signal and let that vessel open up. If we're really cold, then we're going to send that message that says, hey, tighten that blood vessel up. I don't want that blood to go to the skin where I can lose heat more easily. But if we are exercising, if later this week it's supposed to be 95, 97 degrees or something like that, if you're going outside in that heat, you're going to be having a lot of vasodilation going on to help shed heat directly through the skin through a process called radiation, but also to make sweat. In order to make sweat, we don't just have a bunch of liquid hanging out in that sweat gland. We're basically taking liquid out of the plasma from the blood that's flowing through the dermis to then be able to make the sweat from that plasma. So we need to have blood flow to the dermis in order to allow the body to make sweat. So both of those are going to take place because of nerve control of that blood vessel diameter. And then glandular secretion. So when we look at the skin, it's mostly just oil glands to help kind of lubricate things, and then the sweat glands. And the sweat glands are going to be more influenced by environmental conditions than the oil glands. But certainly every time you take a shower and scrub yourself with soap, you're going to strip away the oil off of your skin. And so that's going to kind of be a stimulus for your body. Will recognize, hey, that's kind of dry now. Let's make some more oil and get that skin more lubricated again. So it does respond to a degree, but not as quickly as the minute-to-minute adaptation that sweat glands are gonna make. All right, so I've already talked a fair amount about vasoconstriction, vasodilation. Vaso just refers to blood vessel. So anytime you see that term, vasovascular, avascular, all those terms relate back to the vascular system or the blood vessel system. And usually when we talk about vasoconstriction, and we'll talk about the circulatory system later, when the blood leaves the heart, it goes into big arteries, and then those go into smaller arteries. And then eventually further downstream, it's going to go through what are called arterioles, and then into the capillaries. And the arterioles are really the primary level in the vascular system where we really see a lot of change in diameter to kind of cut blood off from one part of the body and allow it to go to another part of the body. And we talk about it with the skin, but it happens all the time. Certainly if you've eaten something recently, you're going to vasodilate the blood vessels going to your gut to help to support the cell's activity there. If you just ate lunch or breakfast and all of a sudden somebody broke into your house and you had to fight them off and you had to run away or whatever, your body's going to say, you know what, I know you just ate and you want blood flow to your gut to help digest stuff, but right now we've got this intruder that we need to fight, so I really need blood to go to the muscles, because you got to be able to fight, run, whatever. So we will rapidly change where that blood flow is going to meet the body's demands. And in the skin, it's mostly about thermoregulation more than anything else, as well as healing. You know, if you have an injury to the skin, then you're going to send more blood flow to that area to try and help it heal a little bit more easily too. All right, so we've gotten through the epidermis and the dermis. Below that, we're going to have what's called the subcutaneous layer, and it's mostly body fat. We do have some areolar connective tissue, but a lot of it's adipose connective tissue. And so it does give us padding. It does serve as insulation. And so people that tend to not have much body fat will often have a harder time in cold weather. They'll have an easier time in hot weather because they're going to be able to lose that heat more easily because they don't have as much insulation. So if you have more body fat, you tend to be better protected in the winter, but you're going to suffer more in the summer. If you have less body fat, it's kind of the opposite dynamic. And then adipose cells are just our biggest source of energy storage. So that if we did come into a time of famine or extreme fasting or something like that, our body knows, hey, you know what? I got to keep all these cells going. I got to keep the heart pumping. Got to keep the brain, the neurons firing. I'm going to break some of that stored energy out of fat, convert it over into more usable forms so that we can keep the cells alive. All right, so there's our kind of breakdown of the different layers that we've all talked about so far. Epidermis, down into the dermis, and then down into that subcutaneous layer. All right, now we got kind of the extras. So in addition to the skin, we've got stuff attached to the skin. So we look at fingernails and toenails. We talk about the hair follicle. We'll go into that a little bit detail. And then we'll talk about some of the different glands and how they're organized. We talked about glands last time when we talked about epithelial cells. And in the skin, we don't really have endocrine glands. We just have the exocrine glands that have a direct duct to take their secretion to a specific place. All right, so our nails, whether we're talking about fingernails or toenails, they have the same basic structure. And I'm going to go ahead and skip to the slide. I think it's probably easier to kind of talk through these things when you're looking at the diagram here. So here's our fingertip from the top. Here's the cutaway kind of halfway through the nail, and that would be a very painful injury if you had it, because we have lots of sensory receptors in the fingers in particular. But if we look at this top one, kind of from the top, we have what's called the free edge, and that's the part that you clip. That's the whitish part where it's no longer attached to any underlying tissue. It's kind of overhanging, and when it gets too long, we're going to clip it, we're going to file it, we're going to try and manage it so it doesn't become too long. At the base, we have what's called the lanula, and so that's that whitish kind of like crescent moon type shape, and that's where that name comes from, lunar, referring to the moon, this kind of little sliver of whiteness there at the base. The nail bed, or the nail body itself, actually extends underneath the cuticle a little bit further back. So that lanula is visible, but the actual nail is going to come further back. And when we look at this cutaway, you can kind of get an appreciation for how far back it goes. So there's our whitish tip. There's the most of what we kind of think of as our nail body. There's the lanula, and then there's the cuticle, and then the actual fingernail itself, the nail root that we don't see because it's buried underneath, is extending further back to it. The nail matrix is essentially kind of the interface between the cells that are migrating into the nail bed itself, or the nail bed itself, or the nail plate, I should say. So that's that kind of connection, and you do have a pretty good blood supply in that area. If you've ever, ripped off a part of the nail, it's very painful, tends to bleed a lot. If you've ever got a black fingernail or a black toenail from dropping something on your foot, slamming it in the door, something like that, you get bleeding in that area that kind of builds up, and it usually separates that connection. And so typically, if you get any kind of significant bruising and bleeding underneath the nail bed, you're probably going to lose that nail. It's probably going to come off completely because it's just separated and doesn't heal itself back down very well. If you drain it right away, you have a little bit of a chance to do that. But if that blood stays under there for any length of time, you're going to have pretty much a permanent separation, and eventually that nail is just going to kind of come off. How many people have had that lovely experience? More than once. A lot of you. So you know what I'm talking about. All right. So those are kind of the key things on the fingernail to know. Again, I think really just as long as you know the terms on this slide and what they refer to, you should be fine. Any of the other terms that are shown on that diagram, I won't ask you about the eponychium or the hyponychium or any of that kind of stuff. All right, so we look at the hair. We've got different components for that as well. We do have what are called different hair types. And lanugo, that's the little baby hair, kind of that little really fine kind of fuzzy hair that you'll see on their head, but also kind of on their face and other places. And they'll tend to shed that off pretty quickly. And then we get what's called vellus hair, and that's kind of our more most common type of hair. And then terminal hair is going to be more the darker, coarser hair that we get in maturity. So this is kind of more, the vellus hair is more, you can kind of think of it more kind of like our childhood hair. It's not quite the same texture as the more terminal hair that we have when we get older. But regardless of whether it's lanugo, vellus, or terminal hair, it's going to have these three different components that are shown at the bottom of the slide. So let's look at our picture there. And kind of talk through this. So I'm going to focus mostly on this one to the left because that's kind of the easiest one to see, and then we'll kind of compare it to these other slides and look at those a little bit. So here's our hair shaft that's coming up above. So the part that is exposed that we can see, that we can pull on, that we can tweeze or whatever, that's essentially the shaft. Once we pass through and start going down into the epidermis, then we get to the root, essentially. So the root is going to come all the way down until the bottom, and then we have the bulb. So just like a flower that you plant that pops up every spring or whatever, you've got that bulb that's down in the ground, and then the hair is going to grow from that bulb, or that flower is going to grow from that bulb. That's kind of how our hair works. So the bulb is where the business of making hair happens. We had that term papilla or papillary when we looked at that papillary layer between the dermis and the epidermis, and here we see that term again. So it's this kind of projection coming up, so kind of nipple-like. We look at this bottom middle picture here, the hair papillae, and then we have what's called the matrix. And so that matrix, kind of just like the fingernail, is kind of where we really are making a lot of the hair cells itself that are going to become the hair. Once it leaves the matrix, then we start getting into the actual hair itself. And so you're going to have, again, we leave the bulb, we get to the root, and then we get to the shaft. Each individual hair has a few different components to it. It has what's called the cortex, which is the hollow part in the middle, essentially. The medulla is the hollow part in the middle. And medulla kind of means middle. We'll hear that term a lot in anatomy. We have a lot of different body parts that have medulla structures. So we have the medulla is the open space, the cortex, just like our cortical bone. If we think about the shaft of a long bone as the cortical bone, that cortex that surrounds it, that's kind of the same idea here. And then the cuticle is kind of this outer waxy covering to it. So we have the cuticle, the cortex, and the medulla going from outside to inside within each individual hair itself. So that's kind of how our hair is organized and put together. Now attached to it, and we don't really see it as much on this slide. Actually, I think I'll go back to another slide and we'll look at the sweat gland and how that's attached. This red extension coming off of here is the erecti pili muscle. And so pili or pilus, when you see that term, that refers to a hair. And so this erector pili muscle is what gives us goosebumps. When this muscle contracts, it's attached to that kind of right where that papillae is, right where the dermis and the epidermis meet. When it contracts, it's going to pull on that hair root. And when it pulls on that hair root, essentially, it's going to make the exposed shaft stand up straight instead of laying down flat. And so that's what gives us those goosebumps. And they believe it's an evolutionary adaptation to make us look kind of bigger and badder and tougher. And if you think about like dogs and cats, when they get scared, when they get mad, that fur stands up and it makes them look bigger than they are. So if they're facing off with a threat, some other animal, and they can look bigger, well, it's maybe more likely to make that other animal back down. And so they think that's kind of a big part of why we have that response. It also serves to act as insulation. Now, most of us don't have enough body hair to really give us a huge insulation effect. But I think you think about Neanderthal days, when people lived outdoors much more than we do now, don't have air conditioning and central heat and that kind of stuff. They kind of needed their bodies to be able to do more for them. So they tended to be a little bit hairier. And essentially, just like a puffy down jacket or something, that puffiness is because we've got these fibers that can trap heat, whether it's a synthetic insulation or down, but then there's those air spaces in between. And so that's kind of how goosebumps work to help keep us a little bit warmer if we're hairier anyways. It's creating space in between those hairs where that air that's closest to our body can kind of get warmed up and stay closer to our body, so we're not as exposed to colder air that's further away from us. So again, it's not super effective at this point in our life, but those are kind of the two reasons why we have goosebumps. But erector pili muscle is the muscle that gives us the ability to have our hair stand on end. So, all right, so functions of hair, protection. Certainly, when we look at the sun beating down on the top of our head, I think a lot of people, if you part your hair, you may have gotten burned right along your part sometimes because the hair is laying down on either side and it's not kind of covering up that top. If you don't have as much hair, your hair starts thinning, then you're going to be more susceptible to sunburn on the top of your head, certainly for sure. It does help trap heat. Again, that's kind of where that goosebump effect comes into play. Sensory reception. If you think about, the hair on your arms or the hair on your legs, if you don't shave your legs, if you have a little insect or something crawling along your arm, the movement of those hairs is what often alerts us that something is on us. The fact that that hair is shifting activates a sensory receptor deeper in the dermis that says, hey, there's something on you. And you're like, it's a spider or whatever. It definitely gives us that ability. If it's windy out, our hair is going to move in response to that wind, and we're going to pick that information up and get a sense of how strong that wind is, those type of things. So it definitely helps with that. Visual identification certainly helps you recognize people that you know, or, if we look at like long hair versus short hair, sometimes that is like, oh, that person's got long hair, it must be a woman. Well, maybe not. If we look at, gray hair, you're like, oh, that person must be older, they have gray hair. So it does give us that ability. It's not foolproof, and certainly when people start dyeing their hair purple and blue and stuff like that, all bets are off. But it does give us some ability. And when somebody gets their hair, you're like, oh, I didn't recognize you, you got your hair cut, kind of thing. So it does change that. And then chemical signal dispersal. So we do have odor molecules. We'll talk about the apocrine sweat glands that send out pheromones and things like that can kind of help us identify stuff. And certainly animals use that function more than humans do. All right. So let's talk about our glands, and then we'll be just about done. So we're in pretty good shape to finish up on time today. So we talked about the different types of exocrine glands. We had merocrine, we have apocrine. What was the third type? Anybody remember? The third type of exocrine gland. Nope. So merocrine are going to produce the little vesicles. So the secretory cells are going to package up their secretion in a little double phospholipid bilayer membrane so they can leave the area and get into the duct and be traveled away. The apocrine glands are the ones where the secretion is going to build up within the cell a little bit, and then it's going to pinch off a part of that cell. So we have a little bit more cellular debris along with it. So it does cause some cellular damage. And then the third type is the holocrine. And the holocrine is where that secretory cell is just going to keep making its secretion, eventually just pop and release its secretion that way. So the holocrine is the one that's not listed here. So our sweat glands don't work that way. They work either through this merocrine mechanism or this apocrine mechanism. And the merocrine type, they specifically call it an eccrine, so ECCRINE, but it's making vesicles. And then sebaceous glands, that name comes from sebum, which is the oil itself. So these are oil-producing glands. So here's our hair follicle on this diagram here. These little kind of bulbous swellings off the side are the sebaceous glands that are going to be producing the oil. And so it is linked to that little tube that surrounds the hair itself, the root. And so it's basically able to kind of wick its way up the shaft of that hair and get out to the surface of the skin. So that's where we're going to produce the oil that we have. These more convoluted, kind of all twisted up little ducts over here, or glands over here, those are going to be our different types of sweat glands. So they show that eccrine type or the merocrine type here in this lighter purple, and then this more kind of reddish one is going to be the apocrine one. And again, the apocrine one, if you follow its duct, it also kind of ties in where that hair is. So we're using that pathway for the hair shaft and the root of that hair to also serve as the conduit for our stinky sweat glands as well as our oil glands. And so apocrine are the ones that are going to produce odor. The merocrine ones are not really as stinky. So the merocrine, 99% water. So very effective at cooling us off, not creating a whole lot of odor, not going to really create as much like staining of clothes and things like that as the apocrine based ones. So we do have lots of these on our palms of our hands, soles of our feet, and generally on a lot of other parts of our body too for cooling. We don't have sebaceous glands on the soles of our feet or our palms. We don't really want to have a lot of oils on our hands because it would make it hard to hold stuff. We want those friction ridges to have better grip. We also don't have hair coming out of the palm of our hand, and those sebaceous glands are tied to the hair follicle. So the fact that we have no hair here means we don't make oil here. The back of our hand's a different story. We do have hair back there, but the palms of our hands, the soles of our feet, we don't really have the oil producing glands. We just have clear sweat glands there. And again, the main purpose is thermoregulation for those. And then our apocrine are the ones that are going to create more of that stinky smell. We're tearing off a part of the cell, so we've got some cellular debris that has to degrade. That dying off tissue and cellular material is a source of food for bacteria to grow and proliferate on, and that's kind of what creates the odor. If you have like little yellow sweat stains in your armpits and stuff, that's because of the fact that we do have this. It's not as clean of a sweat. It has more cellular debris and more bacteria. So it gives us the odor and the discoloration. And then there's our sebaceous glands, again, producing sebum or oil, goes into the hair follicles and then kind of dumps up and spreads out on the skin. And I don't know, I don't have a daughter, but so I've heard people like to brush their hair like, 100 strokes every night or whatever, and that's going to help spread out the oils on your hair and keep your hair healthier, so you don't get split ends and all that kind of stuff. And it probably does to a degree. The fact that, because we're producing oil right at the root where it's coming out, and if we want that, if you have longer hair, it would make sense that if you brushed it, it would help disperse it and spread it around a little bit more. I'm not going to brush mine 100 times tonight. I will tell you that. All right. So just a few minutes left. Let's talk about skin repair, and then we'll talk about getting old. It's terrible for your skin, especially. And then we'll talk about skin cancers real quick. So this is just a little diagram or sets a slide picture showing you kind of what happens when you injure yourself. So if you have a puncture wound, an incision, a scrape that bleeds, you've gone down into the dermis. You've damaged the tissue through the epidermis and gotten down to the dermis. We wouldn't have blood if we didn't get into the dermis. So in this case, they've kind of gouged this section of tissue out. We got down to capillaries. The capillaries bleed into that area, and we form a clot to stop the bleeding. Once we form that clot, now we've stopped the immediate threat of bleeding out, but now we have this chunk of dead red blood cells that we need to kind of clean up. We've got all the cells that were in the area, in the damaged zone, that got destroyed potentially, and so they're going to have their contents will spilled into that area. Their edges are going to be all jagged and rough, and we kind of need to clean all that stuff up so that we can make new cells. If you think about like repairing a pothole in the road, sometimes they'll do the job halfway, where they'll just like dump in some coal patch tar stuff to fill it. If they don't really do a good preparation on it, that pothole is going to be recreated in a matter of weeks or days. But if they do it right, then they'll kind of cut away the surrounding area, and they'll actually lay down a new chunk of cement or something that's a more permanent and a better fix. It's kind of what the body has to do. Initially, we just filled in the gap, but now we need to do a better job if we really want it to be a lasting fix. And so down at the bottom slides, you see all these little kind of, flattened looking cells down here. These are meant to represent fibroblasts, and fibroblasts are essentially just making collagen. So we have macrophages. That's part of our white blood cell response. That's going to gobble up some of the necrotic tissue, the dead cells. It's going to help clean up some of the dead red blood cells that were part of that scab. And then the fibroblasts are going to be making lots of collagen to fill that gap in. They're not making elastin. They're not making reticular fibers. They're just making collagen. So they're just trying to make a tough patch job. But again, where this is forming, that part of the skin is not going to have the same stretchy ability that it used to have. It might not leak anymore. We've plugged the gap and we covered it and we smoothed it over to a degree, but you're probably going to see a scar. Again, that tissue is not going to move the way that we want it to move necessarily. Over time, it will get smoother and smoother. We kind of do a process called remodeling. But if it's a significant enough injury, you're always going to have a higher percentage of collagen in that area than it did previously. and it's not going to move as freely as it used to because of that collagen and the lack of elastin, really. All right, so when we get older, we don't heal as quickly. Mitosis slows down as we get older in all of our cells. And when we look at the skin, it's going to take a lot longer for an older person that potentially has less metabolically active cells and less vigorous circulation. We lose some collagen, our elasticity declines, so that's where we start getting wrinkles. Our skin doesn't snap back quite as well as it used to, so we start getting more wrinkles. Imagine like a rubber band that's old and no longer you stretch it out and it doesn't really go back. That's kind of what's going on in our skin. Immune response goes down, skin gets drier, we need more lotion. You can start getting darker spots, discolorations become more visible, start losing hair. Pretty much everything doesn't work as well when you get older, but you're not dead, so there's that. All right, last bit, and then we'll take a little break. So skin cancer, by far the most common type of cancer that we have. We don't necessarily have the most deaths from it by any means, but lots and lots of people get cancers, especially people that have lighter skin, especially people that spend a lot of time outdoors where they're exposed to more UV light. So basal cell carcinomas are most common, and that's affecting the cells in that stratum basale layer where we make new cells. These are the least severe of the skin cancers, and a lot of times people will get them frozen off, and then the body can kind of restart the normal skin cell generation process and make healthier cells. Pretty much a cancer is basically a glitch in your DNA, and so then when you start making new cells, they have a flawed structure to them, and they don't work. And so then your body's like, well, that one didn't work, let me make another one. Oh, that one didn't work, let me make another one. Because the blueprint's bad. And so they keep making bad copies, and it just keeps growing and growing and growing. And so if we can freeze these things off down to that basal layer, let the dermis recreate some new basal cells, then a lot of times it'll fix the problem and clean up that spot. So if you hear about people having to go to the dermatologist and getting spots frozen off their face, their shoulders, stuff like that, their hands, it is a pretty easy way to fix these things if they're not very severe. And the basal, as well as the squamous, can be kind of treated that way. The squamous cells are going to be that next layer up, so they're going to be in that spinosum layer. The worst type of skin cancers to get are the melanomas, and those are going to start in the melanocytes. And those are going to usually be the most deadly ones. These are the ones that, again, because moles and freckles and things like that are areas of hyperactive melanocytes, basically, those are the areas where we're most susceptible. And so they will often say, if you have moles and you notice any kind of changes in shape, color, the border of that mole, has it gotten thicker? Are you getting any bleeding around it? Those are all kind of warning signs that you've got some extra activity going on with that patch of skin that you didn't used to have. And that's generally not a good thing to see. They usually say you don't want moles to be any bigger around than an eraser tip. So if you, this is a pen, not a pencil, but if you had a normal number 2 type pencil with a little rubber eraser on it, if your mole is bigger than that, which is I think around 6 millimeters, then it's kind of a warning sign that maybe that is too big. And I have a pretty big mole on my calf that every time I go to the doctor, they're always looking at that. Has that changed? Is that any bigger? Like, no, had it that way my whole life. I'll let you know if something happens, but so far so good. I had a mole taken off the back of this earlobe. When the biopsy came back, they were like, it looks like it could be precancerous, so we're going to take out some more. They took out a wider chunk off the back of it. So my earlobes are different. You might not be able to tell from this image, but this one is my natural one. It kind of hangs down freely. This one kind of tapers in and goes straight into my head because they took a chunk off of it. And then I've had a few patches sizzled off both on my hands and different places on my face and neck and stuff like that. So be ready for it if you're pale and you spend much time outdoors, and don't take it for granted. If you have patches on your skin that are flaky, irritated, those are warning signs that it's kind of either precancerous or has the potential to become kind of precancerous. So you want to get those things looked at sooner rather than later. Like every cancer, the sooner you catch it, the better chance you have of it being minor. The longer you wait, the more chance you have of it being more severe. So, all right, 9:35 on my clock here. So let's take about a 10-minute break, and then we'll kind of jump into some of the lab stuff. We'll start going over the skull a little bit, and then I changed the test or the quiz. We're going to start that at 10:25 to give you just a little bit more time. So take about a 10-minute break, and then we'll do about 40 minutes going over different bones in the skull, and then we'll take our quiz and be done. So I'm going to make a pit stop and see if we'll be back in about 10. All right, looks like 9:45, so I'm going to get rolling here. So I pulled up this set of slides is from the Lab 3 module. I'm going to probably shift back and forth between showing you the models that I have in my office here, as well as the images on the slide. So I'll probably go back and forth between sharing my screen and just letting you look at my video image. So we're going to go over the cranial bones first. These are easier, they're bigger. A lot of them are named based on the lobe of the brain that they cover. So when we learn the lobes of the brain here a little bit down the road, that will all make sense and you'll be familiar with all those terms too. The facial bones are a lot smaller, a lot harder to pick out in some cases, so they are a little bit harder to memorize and keep straight. So if it's a cranial bone, it means that the bone is coming in contact with the brain, making up what we call the cranial vault or the cranial cavity. If it's a facial bone, it's not. And so we do, like I said, we do see some big ones here. Frontal bone is basically your forehead bone, and it does come down into the eye sockets a little bit. This is my frontal bone on the model, one of the models that I have. And so you can see the eye sockets, kind of the back part of the eye sockets, and the superior portion of the eye sockets is part of that. If we look at a whole skull, and right there, that's all frontal bone, and then that's coming down into the eye sockets itself. Parietal bones are the big ones on the side. So you're going to meet right in the center. You can feel that center kind of ridge line right on the top of your head where those two parietal bones meet. So we have one frontal bone, but we have two parietal bones. And then on the back, we have one occipital bone. So a lot of these bones are set up in pairs where we're going to have a right and a left. But the ones directly on the front and the back, we just have one of each. So one frontal, one occipital, and then two parietal. If we come down a little bit further on the side, then we have our temporal bones. And again, we're going to have two temporal bones, one on each side. So far we've got a frontal, that's one, an occipital, that's two, the two parietals, now we're up to four. Now we have two temporal bones, 5, 6. So we only have 8 cranial bones. So now we've just got number 7 and number 8. And so that's these two that are shown up here, the sphenoid and the ethmoid. The sphenoid is the bigger of the two. And it's probably my favorite bone in the skull because it reminds me of a butterfly.
Is it because it's the floor of the skull?
What's that?
It's the floor of the skull for your brain?
For part of it, yeah, more kind of on the front part. It makes up a good part of the floor of it. So it's going to sit in our brain kind of like this, essentially. And we can see it from a lot of different angles. We'll kind of look at some other models of the skull, both from the inside and the underside, to kind of help pick out and identify where this bone is. So it's very irregularly shaped. It has a lot of little crevices and holes and little projections. So this is an irregular bone. A lot of the bones of the cranium are those flat bones. If you remember the different bone types that we talked about, these ones that are big covering plates are going to be flatter bones. When we look at the facial bones, then we've got the things that make up our jaw. So we've got the mandible and the maxilla. The maxilla is the top jaw, essentially. The mandible is the bottom part of the jaw. And then around the nose, you've got a whole bunch of different ones. I'm going to give a different angle, a different viewpoint. We'll kind of look at some of those. So pink down on the bottom, that's our mandible. This kind of more peachy, kind of orangish color one is the maxilla. And so you can see the maxilla goes up pretty high. It actually forms part of the eye socket too, kind of at the bottom in there. The eye sockets are tough because we've got about a half a dozen different bones that make them up. It's not just one individual bone. And I like these images that give you different colors because it makes it a lot easier to kind of see where each individual bone is located. When we look at just a normal skull model, we don't get it color coded, so we kind of have to identify those things a little bit. It's a little bit harder to identify those things. If we look at the nasal region kind of right in the front, we're going to have two nasal bones, and those are going to be kind of the upper part of our nose. So kind of on either side of our eye, but not necessarily very far back in. So they're going to be the most superficial, kind of what we think of as the bridge of our nose. That's kind of our nasal bones. Right behind them, posterior and kind of deeper into our eye sockets, are going to be the lacrimal bones. And we're going to have a right and left those. And lacrimal just refers to tears. Any of you read the Lemony Snicket's books ever, or watch the movie? They had Lake Lacrimose, literally means the lake of tears. That what the aunt lived there, I think, Aunt Josephine or something like that. So lacrimal refers to tears. So that's this little blue one on this image tucked back in there. So it's not a very big bone. We'll look at that in a bit individually. Inside that nasal cavity, if we take the soft tissue kind of part off of our nose, then we've got a few other bones in there. So we've got one that's coming straight down in the center. That's called the vomer. And then we have a couple little ones that kind of flare off for the side, and that's called the inferior nasal conchae. We have a superior one, but it's actually part of another bone. And then the ethmoid, we can see that a little bit in there too. The ethmoid in this one is a kind of a purple coloration. This is the ethmoid bone taken out. And it would be oriented in our skull kind of this way, back in here. So ethmoid's significantly smaller than the sphenoid. These are models, and so I'm holding them up in front of my little camera. You can kind of see the difference in shape and size between those two. All the other facial bones are significantly, or all the other cranial bones are significantly bigger. But like I say, all these little facial ones are all pretty small. Let's look at a couple other viewpoints. So here's the top of the skull, and this is looking at what we call our suture lines. And so the suture lines in the skull are essentially where the big plates meet up. You can think of like the fault lines in an earthquake type of situation, kind of where the different plates of the skull are kind of going to be joined together. And this is considered a joint. It's a fibrous joint, so it fuses as we go into adulthood. You know, when we're first born, we have soft spots called fontanelles, and these bones are not fused together on that kid that's inside of mom. And moms should be glad that they are not fused together, because it gives that child's skull a little bit of flexibility, so that as they're trying to make their great escape, their skull gives a little bit. Not enough, I'm quite sure, for any of you moms in the room. But that does help a little bit. Over time, as we go through growing up, childhood, adulthood, those soft spots kind of go away and they fuse together. So you do want to know the names of these different suture lines. So we have the coronal suture, is the one that's in the coronal plane. It's basically where the frontal bone meets those two parietal bones. We have the sagittal suture, so just like the sagittal plane. That's the plane that splits us into right or left halves. That's essentially where the parietal bones meet on top, running front to back. So those two are just like the planes that we talked about. So those are pretty easy to keep straight. On the back, and we'll look at a different view to look at this one a little bit more, we have what's called the lambdoid suture. And so that looks kind of like it's kind of V-shaped, upside down. Let me hold up this version of the skull, and you can see it a little bit better. So this, my color-coded model, the purple bone is the occipital bone, that's the back of your head, and that lambdoid suture is where these two green sections of the parietal bones are meeting, so this line along here. Now within the lambdoid suture in particular, a lot of times we'll have what are called sutural bones or Wormian bones, and that's what, let me look at a different image and you can see that. So these little green ones, that are kind of embedded in there. We've got again, on this slide, we've got blue for the parietal bones and we've got purple for the occipital. That's the lambdoid suture, is this big line, but then these separate little bones that are kind of filling in the gap are what we call wormian or sutural bones right in there. They're not considered a distinct bone like a parietal bone or occipital bone. Some people are going to have them, some people aren't. Some people might have more than one, some people might only have one. So they're not typically thought of as one of the cranial bones. They're just kind of a bony fragment that's filling in the gap, more or less. And then we have one other suture that we can only see really from the side, and that's the squamous suture. So between this kind of yellowy peach color for the temporal bone and the blue for the parietal bone, that's kind of where that squamous is going to run. That squamous suture does also really include part of the sphenoid. So that purple bone right there is part of your sphenoid bone on the side. And then this region called the pterion, the P is silent, like pterodactyl. It's kind of like the four corners region. It's where we've got lots of bones coming together. So we've got the frontal bone, we've got the sphenoid bone, we've got the parietal bone, we've got the temporal bone. They're kind of all meeting in that region. And that's kind of the softer spot of our temple. If you kind of push on your temple there on the side, where it's a little bit more tender, that's kind of where all these individual bones are meeting up and kind of joining. So that's that pterion. So those four sutures, you definitely want to know: frontal, or excuse me, coronal, sagittal, squamous, and lambdoid are the four sutures. I did not talk about the zygomatic bone, which I should have. Let me go back a slide or two. There we go. So the zygomatic bone is what we think of as our cheekbone. So the most prominent part kind of laterally here is the zygomatic bone. And you can see that it's this greenish one in this picture. So it does kind of extend up onto the lateral part of the eye socket and kind of form the back portion of that eye socket as well. But it also is going to run back behind towards the temporal bone. And we've got a couple different bony features that you do need to know on these bones. And this will all be on next week's quiz. And we'll go over this all again and spend a little more time on Thursday in lab, letting you guys work through all these things. All right, so looking at this interior view. And so this would be a sagittal view. We've cut away half of the skull and just looking at essentially the right half of this skull. So we've got our pink kind of frontal, we've got our blue parietal, we've got our purple occipital, and then our kind of peachy colored temporal bone. All of this central portion that's purple, that's our sphenoid. And we have a few distinct features on that sphenoid when we look at that. If I'm holding up this one here, actually I should put it this way. This is kind of the view that you're seeing of that sphenoid. It's cut away. And so you see this hollow space in the middle. That's one of our sinus cavities. So that's the sphenoidal sinus. What I wanted to point out was this kind of U-shaped section in the middle there. And so that U-shaped section is called the sella turcica. And that's essentially where my fingertip is, kind of in here on this one. Going there. I guess it would be oriented this way. This is the back. This would be the front. And so that sella turcica, sella means saddle. Turcica means Turkish. So it literally means Turkish saddle. And it's basically, I think, like the type of saddle that they would put on a camel. So the person's backside is up against this back part and they're sitting down in this little pocket. What actually sits down in that little pocket there is our pituitary gland. So the sella turcica is essentially a bony protective covering for the pituitary gland. And part of the hypothalamus is going to drop down into that space because that's what connects the pituitary to the rest of the brain. So that's a kind of a key feature to be able to recognize on that sphenoidal bone. The ethmoid bone is this reddish section And it has a few distinct features that kind of come off of the top of it. I'm going to quit sharing my screen so you can see this a little better. All right, so you just see me now? Or do you still see the image? You should just see me, hopefully. So this is my ethmoid bone from the side. This would be looking at it from the front. And so when you look at it from the front, we've got this distinct little fin coming up off the top. That's called the crista galli, this bony section that pops up right there. If I'm going to turn it sideways now, you're looking at it kind of from the top down. On either side of it, and you probably can't tell, it's probably better to look at an image in your book, there's a series of little holes. And those little holes are called the cribriform plate. Those little holes are where the olfactory nerve, which is the nerve that picks up smells, is going to have a bunch of little finger-like projections that hang down into our sinus cavities. And so they're chemical receptors. And so when odors come in to our nose, they basically hit our mucus, and those chemicals that are creating an odor, let's say it's fresh cut grass, are going to become in solution in that mucus, and then that gives the receptor the ability to pick up that scent. But it does poke down through those little holes in the cribriform plate, which are on either side of the crista galli. All right, here's a great underside picture. And we do have a few things to kind of notice back here. On the back of our skull, we have what's called the occipital protuberance. And you should be able to feel that on the back of your own skull. It's basically right where your skull is going to start kind of curving back under. If you're going on the most posterior part of the skull and kind of dipping down, you're going to kind of feel it underneath there. I realize you're not seeing my screen anymore, so I better change that. I was showing you this cool picture and nobody could see it. So this picture right here. So here's our occipital protuberance right in the back. You have a few other lines, and these are just places where muscles are going to attach typically. We have this big hole in our head, foramen magnum. Magnum means big, foramen means hole, so that's the biggest hole in our head. I guess other than our mouth. If we open our mouth, that'd be a bigger hole. But this is where our spinal cord is going to come down. Other prominent things on the occipital bone, these little oval-shaped portions that are kind of on the anterior side. Again, their teeth, this is the front where the teeth are. This is where the base of the skull is going to sit on top of our first cervical vertebrae. So these occipital condyles is what we call them. They're going to be covered with that hyaline cartilage. We want them to be nice and smooth so that when they sit on top of our first cervical vertebrae, they have a place to kind of rock back and forth. And that's what they're good at doing, is kind of the front to back motion with our head. This whole big purple section that we see underneath here is the sphenoid bone. And then moving more anterior, we've got the vomer, is that yellow bone. We only have one of those. That's kind of the one we see. If we take all the soft tissue of the nose off, it's going to be right center in the middle, kind of hanging straight down, that vomer. And then these green little ones are the palatine bones. So those are the back part of our hard palate. The front part of our hard palate, this more peach color, that's the maxilla. So that's our upper jawbone. And then our teeth are embedded in that. But if we go further back towards the back of our throat, for a while there, we're going to be on the maxilla, but then eventually we're going to hit these two palatine bones. So we'll have a right and a left palatine bone, and then you'll get into the soft palate, where you could, if you're pushing on the roof of your mouth, you can kind of feel where we just go into soft tissue, where it's just more of a muscular layer. And that's kind of where these holes are, right in there. Over on the side, you get kind of an appreciation of this green zygomatic bone, and then we have this space right there. So that hole right there is basically being formed from this extension coming off, this yellowish extension coming off the temporal bone, and this green extension coming off the zygomatic bone. And so essentially we have on the temporal bone, we're going to have a zygomatic process. They're going to meet where that little line is. On the zygomatic bone, we're going to have a temporal process. So we have a process on each bone that's named by the bone it is heading to. And I think those are a couple of the terms that you'll need to know when we look at our bone list for that. Let's look at the inside real quick. So this is if I take the top of the skull off. So I've just decapitated this person. Well, not decapitated, but just crowned him. And we're looking at this view right here. So that's what slide is up right now. It's just like this. And so if we look at this view, we can kind of see some of the other things that I pointed out earlier. Where this red section is right in the middle. It's hard to tell two-dimensionally, but you're going to have a little fin sticking up. Think of like a dorsal fin on a dolphin or a shark or something. That's the crista galli. And then on either side of that, you're going to have a series of holes for those nerve endings from the olfactory nerve that are going to drop down into our sinus cavities. And that's poking through that cribriform plate. And that's the section of bone that has those holes in it. Here's our sphenoid. Looks kind of like a bird flying with this little head right there from this angle. And right there in the center of it is going to be that sella turcica, where that pituitary gland sits. And then we come back to the occipital bone, again, the foramen magnum, that big hole in the head. We've got the temporal bones, are these yellow ones. The parietal bones are the blue ones, and so forth. So those are kind of the different viewpoints of the skull to kind of be familiar with. And you will have quiz questions, probably asking all those different things and a few different features, some of the more prominent features to kind of pick out. We talked about the sutures already. I'm going to skip through those. Yep, cranial. I'm going to skip through these individual ones. Actually, let me point out just a couple things on each of these that are key. If we look at this frontal bone, we have this portion termed the glabella, and that's essentially right in between our eyebrows. So this part of it, for most of us, you're going to have a little bit of an indented area, kind of right in the center there. That's the glabella. And then the superciliary arch, cilia, like hair, that's essentially where your eyebrows are going to sit. So the superciliary arch is the part of the frontal bone that creates our eyebrow ridges. I think those are really the only identifying structures that you need to know on the frontal bone, other than the bone itself and the coronal suture. So the glabella and that superciliary arch. With the parietal bone, this is looking at the side. There's no features that I think I asked questions about other than the sutures that it creates. So the parietal bone is going to be part of four different sutures. So all four of them. Meeting at the center, the two parietal bones right on the top of our skull, it's going to be our sagittal suture. Where the frontal bone meets those two parietal bones is that coronal suture. Where the parietal and the temporal meet is going to be that squamous. And then where the parietals and the occipital meet, we're going to have that lambdoid. So the parietal bone is the one that really is kind of part of all four of those suture lines. But other than that, it's pretty flat and smooth. There's not a lot of other identifying bones or features to pick out on. Now here's our temporal bone. If I hold this one up, it's this pinkish looking one. And so they've got the person's bone kind of angled this way. So this little extension coming right here is that zygomatic process of the temporal bone. It's going to meet up with the zygomatic bone itself, and the zygomatic bone has a temporal process that's going to join right there. So those two bones make up that arch. When we looked at that underside view of the skull, this little arch part right here. So this is our zygomatic. I'm looking at, there's the teeth. So here's our zygomatic bone. And as it's coming back, that's going to be the temporal process of the zygomatic bone. And then coming off the temporal bone moving forward is going to be the zygomatic process of the temporal bone. So you want to make sure you're clear on which part is which. And again, the process is named by the bone it's going to, not the bone it's coming off of. The other big thing that we have on the temporal bone is the external auditory meatus, and that's your ear hole, essentially, right through there. So that's where sound's going to come into our ear, through that external auditory meatus. Occipital bone, the key things there is going to be that occipital protuberance, and then the occipital condyles that I mentioned earlier, and then the foramen magnum are kind of the big things with that one. And then our sphenoid, I don't think I asked anything other than the sella turcica on this. I'll double check my list. There might be a couple of these foramen that you need to know too, but we'll have one more session to kind of clarify that. So different views of the sphenoid, and it does look very different from each position. And then here's our ethmoid just by itself. So this is the one that has that crista galli. You can kind of see the perforations in this slide a little bit better, maybe where those holes are. And those are the key things looking at that one. This bottom view is looking at it from the front. So there's the crista galli poking up. And then we have what's called the perpendicular plate that comes down. And that perpendicular plate is going to meet with the vomer. So it's going to come straight down kind of through the center portion of our sinuses. All these irregular bone surfaces in here are what make up a lot of our sinuses. So these hollow spaces in the sphenoid and the ethmoid, and we have some in the frontal bone as well as the zygomatic, are sinus cavities. The maxilla has some sinus cavities too. So those are just hollow spaces, except when they get full of snot and boogers and stuff like that. Then they're not so hollow. So here's our side view, our cutaway view. We also have on the bottom of the sphenoid these pterygoid processes that are sticking down, and then some styloid processes too. The perpendicular plates are these flared parts coming off the bottom. This would be facing forward. So these are these perpendicular plates. We have a lateral one and a medial one on each side that we have. A little hard to see on this vision. Let's go back one right there. So lateral pterygoid plate right there, and then the medial pterygoid plate right there. All right, we've got our zygomatic. Lacrimal is this little blue one. Again, this is a nice one to kind of get an appreciation of how the eye is put together. We've got the pink part of the frontal bone, the green, the zygomatic. In the back, the very posterior part, we've got the part of the sphenoid, and then the maxilla is this more pale orange color that's making that up, and then that lacrimal bone as well. So we've got a number of different bones that contribute to making up that eye socket. Now we've got a few cavities or gaps where the bone is not totally sealed in those eye sockets. And so we've got what are called two fissures, and a fissure is more of like a line, kind of a seam that's not joined together. So we have a superior orbital fissure. An orbital just refers to the eye. And then we have an inferior orbital fissure. And these run kind of diagonally. So the superior ones are kind of like this. The inferior ones are kind of like this. And then right in the center, you can't really see it from this image very well, we have the optic canal. And that's going to be more round. It's not going to be as much of a little slit as it is a circle. And that's where the optic nerve coming from our eyeball itself is going to go back and then go back into our brain so we can pick up light and images. I'm going to hold this skull up a little bit and see if you can kind of, let me stop sharing and we can try and pick out these different openings. So if I tilt my skull just a little bit, you can see the optic canal is right there, more round. To the side of it, going up this way diagonally, that's the superior orbital fissure, and then the one going more diagonally this way is the inferior orbital fissure. So hopefully you can kind of see those things now. So again, the most medial one, that's the roundest, is the optic canal. The two ones that are more diagonal are the fissures, and then you just have to remember, is it the superior or is it the inferior? So those are other ones that I might ask about with that. Nasal bones, nothing specific on nasal bones, nothing really specific on inferior nasal conchi as far as that goes, or with the palatine bones. Now with the maxilla and the mandible, we've got a few different features to look at. The mandible, you've got the mental protuberance. That's essentially the front part of our chin, kind of where we have a little bony ridge there. And then we have mental foramen. And anytime you see foramen, it just means a hole. And so mental foramen just means we got two little holes right there. I think they're just for little arteries to poke through with that. Maxilla. I'm trying to think of what other features. Let me pull up another document real quick. And oops. I'll go back to share my screen. All right. So this is that same axial bone list that I had you start picking out the identifying features on the vertebrae and the ribs and things. At the very top are all the stuff that you're going to need for the skull. So these are the top half of this page are all the terms and areas that would potentially be on next week's quiz. So these are the things that you're going to need to work on studying this week to get ready for that quiz. So we've talked about a lot of the bones in general, and that kind of ends at nasal, are kind of all the individual bones. And then we start getting into features on bones. And so the mastoid process is right here behind the back of your ear. This bone right there is the mastoid process. The pterion we talked about is that kind of central area where we kind of have four different bones coming together near the side of our temple. The optic foramen, that's the same thing as the optic canal. The nasal conchi, we do have superior and inferior. Those are going to be, the only place you would view those are going to be if you have an image like this one looking straight into the nose. And they're just the little kind of flared bone pieces that are sticking out kind of like right there would be the inferior ones, and the superior ones would be up a little bit higher, looking at that space. Foramen magnum, we talked about styloid process. The styloid process are really sharp, jagged little points right here. If we look at the side of this skull, that's our external auditory meatus. So right below that, you can see that little spike coming down. And that's our styloid process. So just like a stylus on the pen is a sharp little pen-like projection, that's what the styloid process is. Sella turcica we've talked about, cristagalli, cribriform plate, glabella, external auditory meatus. Foramen magnum's on there twice, so that might be important. No, I think that's just a typo. Occipital condyle we talked about. Optic foramen's on there twice too. How about that? Otherwise, I think we've talked about just about everything. The carotid canal and jugular foramen are the only two that we didn't really look at. Let's go back to a image that we can see those on. But otherwise, I think we've talked about everything That's up there. We'll go over the mandible just a little bit to look at those structures too. Okay, I wanted to kind of check for myself what we're looking at. All right, so let me back up and find those foramen for you. All right, so we have a jugular foramen. Is going to be right there, kind of where the occipital bone and the temporal bone meet. And then I'm trying to find the carotid one. I don't see it on that slide. I'll have to find that for you and point that out the next time since we're getting close to being at the end of time. Let's look at the jaw really quickly. And I'll point out a few features on that one, and then we'll let you guys get over into Canvas so that you can take the quiz. That's just a gruesome picture. This is an actual cadaver that they basically just cut off the diagonal slice off the front of their face. Kind of gruesome looking. All right, mandible. Where's my mandible? There we go. So mandible, we have what's called the body, and that's the lower part. We have the angle where we kind of bend, and then we have what's called the ramus. So the ramus is the part that's going up and is going to meet kind of right by our ear at our TMJ, but the body is the more part that our teeth are sunk into. The ramus is this extension. And then we've got a couple other processes coming off of it. If we look at this one here, we have the head of the mandible, and that's if you put your hand on your TMJ joint just below your, or just kind of in front and below your external auditory meatus, open and close your jaw, you'll feel that head of the mandible kind of moving right there. We have the mandibular notch, and then we have what's called a cornoid process at the front. So that cornoid process is that more anterior kind of pointy part of it. Not to be confused with the condylar process. So a condyle is a rounded bony end. So the ramus has a condyle that's kind of this whole big section jutting up posteriorly. And the condylar process on the end of it is going to have the head of the mandible. On the front side of the mandibular notch, we're going to have the cornoid process. So those are kind of the big things on that lateral view for the mandible. And again, we'll revisit all this stuff next week or next session and kind of help you work through some of these things. But I think we're about out of time. So I have the quiz set for 10:25 until 10:45. So I'll give you 20 minutes to knock it out. And so go ahead and jump over there. I think it's 10:23 on my computer, but once 10:25 hits, then you should be eligible to take it. Go ahead and keep your webcams on until you're finished with the test. If you have a question during the quiz, just send it to me through the chat box, and that way we won't disturb the rest of the class with it. And I gotta get my chat box visible again. There we go. All right. So questions, anything? Okay, and if you do have questions about the test coming up, there's a study guide for Thursday's test that should be posted on Canvas. But feel free to send me a message if you have questions on any of that stuff as you're studying. I did ask our campus director about the possibility of moving labs on site. She was on vacation, so I have not heard back from her yet about that. But as soon as I hear back from her, I'll let you guys know.
Yeah, actually, medicine has a point. It says it doesn't unlock until 10:45. Craig, you're mute.
Let me check on that. It should be when it locks, but I'll pop in there and see what I can change. Because I changed that before class and I could have sworn I had it set correctly.
Oh wait, no, I was wrong. It says it's due by 10:45. It's open at 10:25. Okay.
Yeah, so it should be available. No, not yet.
Craig, you're muted. Did I just type?
The skull is not, and it's not going to be in the test for Thursday, right?
Ask me the question one more time.
Oh, so the skull, is it going to be on the test for Thursday?
No, it'll just be the first 5 chapters from the book. So all the lecture content.
So none of the bones, so none of the lab stuff?
Correct.
Okay.
Yeah.
So just the tissue and cells.
Yeah, pretty much. The planes and all that kind of stuff.
Yeah.
We went over the first week, and then the body systems, the cavities, cell types, the tissue types.
Awesome.
All that stuff.
Thank you so much.
I'm guessing you're able to get back in, Tom?
Yeah.